Welcome everyone to MVC's last post-discharge follow-up work group of 2024. I am very excited to be hosting this for you today. I'm the engagement manager for MVC, Jessica Sova, for those that I haven't met yet. Um, and I'm going to just quickly go over a couple of things. I'm sure you're all pretty familiar with this now. I see lots of familiar names from previous work groups, but we will be recording this session and it will be made available to you on our YouTube channel later. We have the chat feature open for you to put questions in if you'd like. However, our presenters are happy to also take questions throughout the presentation. So feel free to raise your hand if you have burning questions. Some of the questions might be answered a little bit later in the slides, but feel free to raise your hand and speak up. And then at the end, we will be giving you the link to the post work group feedback survey for those that are joining to get credit for P4P. You will have to submit that in order to get credit for attendance today. So with that, I am going to introduce you to our presenters. Crystal Young is a seasoned healthcare leader and registered nurse with over 20 years of experience driving transformation change in patient care. Crystal earned her bachelor's degree from Ohio University and Master's of Science in Nursing from Grand Canyon University. Notably, Crystal co-led the Michigan Physician Orders of Scope of Treatment, MyPost, Education Committee for Clinicians and Hospital Care Teams. In August of 2024, Crystal and the MyPost Committee provided recommendations to the Health Information Technology Committee to advance care for seriously ill patients. Crystal's transition to data-driven work began with tracking key advanced care planning metrics such as advanced directive completion and quality, ACP conversations, staff training in ACP, and palliative care hospice consults. In her current role as the Quality, Safety, and Experience Program Manager, Crystal leverages data analytics to drive excellence in care delivery, patient satisfaction, and innovative solutions. We also have Natalie Holland, who is a senior advisor with strategic alignment and engagement team in the Office of Policy and Planning at the Michigan Department of Health and Human Services. In her role, Natalie supports strategic initiatives related to high information exchange, health information technology, and the development of statewide community information exchange. Previously, Natalie worked closely on the state's opioid strategic plan, focusing on increasing community-level access to naloxone and opioid overdose reversal medication. Prior to working at MDHHS, Natalie worked for the Michigan House of Representatives as a legislative aide for legislators serving Metro Detroit communities and the Thumb region. Natalie earned her BA at Michigan State University. So I'm going to go ahead and let Crystal share her screen. I will stop sharing mine so that she can share this incredible work that they've done.
Thanks, everyone. And maybe I'll kick it off with just some of our objectives. And Crystal, I think maybe you're sharing the speaker side, but so thanks for joining us. We're here to talk about MyPost. Crystal and I work together closely on the MyPost Advisory Committee, which is why DHHS is in the room with Crystal to help support presenting this MyPost initiative. So we've been convening as a group for just over a year and a half together. And as part of that work, we developed some trainings and have been going around the state and speaking with different groups about the MyPost just to raise awareness around advanced care planning and usage of the MyPost. So what are we going to get up to today? We're going to talk through the POLST paradigm and evolution of MyPost, the purpose of the MyPost form, our general rules around it, how to complete the MyPost, and then, of course, the rules around reaffirming, revoking, and compliance. And then we also have some updates around what the department is doing to support advanced care planning and what the advisory committee has done to help move the MyPost forward. So I think we might still be seeing, Crystal, the versus the presentation mode, we're seeing the speaker mode, so you might need to change which screen you're sharing. But while Crystal's doing that, we did want to get a sense of who knows what the MyPost is. So I'm gonna put that question in the chat and would love to see um, what if you know about the MyPost or if this is just something brand new that we're learning about today. Great. Yeah, I feel like that first response is what we often hear. Heard about it, but not much more than that. Okay. Okay. Cool. Well, I think awesome.
I can go ahead and screen share if you'd like.
Yeah, do you have the slides?
Yep, I have
Okay.
them.
All right. Sorry. For some reason,
That's
on here
okay.
it was
Thanks,
sharing it.
Jessica.
No problem.
You
Yeah.
can
So
take those
what
more
did we
slides.
hear in the chat so far?
We heard a lot of heard of it, but not much more than that. So today we're going
Okay.
to really get into the details of what the MyPost is and how to use it. And hopefully that will help support you guys in integrating the MyPost into some of the advanced care practices in different settings. But I'll pass it over to Crystal.
Thank you, Natalie, and I'm very appreciative for you to join me today. So I'm also curious if anybody has heard of advanced care planning. And basically, the advanced care planning is the process of deciding, discussing, and documenting treatment preferences, discussing health situations and what matters most to you, and deciding who you should choose to be your patient advocate, which is the legal designation of a person to make your decisions for you in the state of Michigan. And then documenting those things on a durable power of attorney healthcare form, the living will, which is a treatment preferences form, and then the medical orders, which would be an out-of-hospital DNR or the MyPost, which is what we're going to specifically talk about today. So curious if anybody has done any advanced care planning for themselves. Feel free to unmute yourself or share in the chat. If you've had a legal designation of a patient advocate or if you've had any treatment preferences outlined. Anyone? It looks like Jessica has. And I actually have an advanced directive. And oftentimes people assume that advanced care planning or advanced directives are for those that are older, frail, maybe, seriously ill. And really advanced care planning is for any adult over the age of 18. And the intention is to outline your treatment preferences at the time and to really designate someone that would follow your wishes and will follow through with those. So if you have not done so, I really encourage everyone to do that, hopefully after you get off the call today. Next slide, please.
So thank you, Crystal, for going over some of the kind of overarching world of advanced care planning, but we wanted to share a little bit more specific around the POLST paradigm. So the physician, the POLST paradigm overall. So in the 1990s, medical ethicists really discovered that patients' preferences for end-of-life care were not being consistently honored, and advanced directives were really inadequate for patients with serious illness or frailty. And so a group of stakeholders at the national level developed a new tool for honoring patients' wishes for end-of-life treatment. And that program became known as the Physician Orders for Life-Sustaining Treatment, the POLST paradigm, that really captured a portable medical order set. And in 1991, a task force formed with a group of healthcare professionals, including EMS, medicine, nursing, hospice, and long-term care. And their purpose was really to continue moving forward the POLST paradigm and branching it out into additional states. In 1993, that worked changed to POLST to distinguish the medical order form more clearly from a traditional advanced care directive. And the POLST became known as the process and also the portable medical order set. So in jumping to 2001, the National POST Form added nurse practitioners and physician assistants as signers in 2001 and 2007. And then over the next 10 years across the country, you saw POLST paradigms cropping up in different states around the country and at the state level. And in 2011, Michigan created the MyPost program, calling it the Michigan Physician Orders for Scope of Treatment. In order to help implement the POST here in Michigan from 2012 to 2015, Honoring Healthcare Choices Michigan formed and helped lead a pilot for the MyPost, specifically in 3 counties, Jackson, Escanaba, and Grand Traverse County. And then eventually it branched out into the Upper Peninsula, covering most of the Upper Peninsula with a pilot to help support the MyPost paradigm. In 2017, the National POLST Task Force changed their governance structure, and the National POST Organization changed the POLST to redefine it as a portable medical order versus using the POLST acronym. And February 2017, when the results of the pilot in Michigan were brought together and reviewed, legislation was introduced to create the Michigan Physician Orders for Scope of Treatment in line with the national movement around POST. And in November of 2017, Public Act 154 was signed into law by Governor Snyder. And so today, what we've seen through implementation of the POLST since 2017 is that DHHS formed a committee to create the specific MyPost form, to draft rules, and to draft an information sheet, as well as translate it into additional languages for accessibility. And then in 2022, MyPost was being used in the field, and final rules were put out by the Licensing and Regulatory Affairs Department and completed in 2022. And as of June 2023, there's a new MyPost form on the website that was updated by the department in partnership with advocates from across the state, including Crystal. And we now have a new MyPost form on our state website for use in the field. But what is, and maybe you could take us to the next slide. So what really is the purpose of the MyPost in the context of other advanced care planning documents? The MyPost is really intended to create a system to communicate patient wishes regarding medical treatment during the last year of life. It's really intended to guide care when patients are unable to speak for themselves. It's immediately actionable. It's a portable medical order that directs care specifically by emergency medical services, and it's advisory and acute care. And it's based on the principles of informed consent, similar to our other advanced care planning documents. In practice, if you would take us to the next slide. In practice, we kind of developed a scenario to help display how the MyPost would work. So this is our scenario 1 patient, Edward. He's a 78-year-old man. He has congestive heart failure and has been hospitalized 3 times over the past 6 months. Edward is able to talk to his primary care provider, a nurse practitioner in this case, who has signing authority on a MyPost. And they're able to indicate that his congestive heart failure has progressed and that they're able to have a conversation and engage in an advanced care planning process to acknowledge that he does not want to endure repeated hospitalizations. And so in partnership with the nurse practitioner, Edward is able to complete the MyPost form to indicate do not resuscitate and comfort-focused treatment. And the diagnosis supporting the MyPost is the congestive heart failure. In practice, this means now Edward has his portable medical order, the MyPost form, and it really is helping to serve him in avoiding unnecessary hospitalizations, which is his wishes, and avoid aggressive medical interventions. If you could, yeah, thank you. So just to go over a couple of the general rules of the MyPost a little bit more in details. So the MyPost is really for adult patients with advanced illness or frailty nearing the end of life, which is defined as having 12 months or less predicted life. It's a voluntary form. It cannot be required for admission to any healthcare community facility setting. It's a standard form. As I was mentioning, we just recently, in partnership with the MyPost Advisory Committee, updated the latest MyPost form in June of 2023. And electronic copies are available on our MyPost website. Maybe you could drop in the chat, Crystal, our MDHHS MyPost website, so folks can take a look at it. The standard form must be printed on pink 65-pound cardstock with a pink border or paper of similar style and quality to make the form easily identifiable. And the department has made available electronic blank copies, and those can be found on our MyPost website. In terms of the original versus copies of the MyPost form, the original form is the property of the patient and travels with the patient. It fills that role of the portable medical order. Copies of the form are permissible and valid, but the most original form remains the property of the patient. Any copies that are taken must be taken from the original form, of course, and healthcare facilities and physician offices are expected to retain the most current copy of the patient's MyPost form in their medical record. Thank you. Just moving on to some of the other general rules. So the MyPost is binding in any healthcare facility other than acute care. The acute care settings should utilize the MyPost as evidence of the patient's healthcare decisions when evaluating the patient. They should recognize that the MyPost is the result of the advanced care planning process and really captures the patient's wishes. However, treatments may differ according to the best clinical judgment of the healthcare professional currently treating the patient in that setting. Ultimately, the MyPost is intended to direct care provided by emergency medical services. That's in the legislation. The MyPost directs the care provided by EMS, and in implementation, EMS has developed a statewide protocol established by the department in partnership with our partners in the Bureau of EMS and Trauma. And we've been undergoing a process of training EMS professionals across the state to be able to honor and utilize the MyPost in the field. The MyPost is valid 1 year from the most recent attending healthcare professional signature date. So it has 1 year of validity, and then it needs to be reaffirmed with the patient and their care team. And then finally, forms completed after June 30th, 2023 must use the MyPost form that was most recently updated and put on the DHHS website. So we might have skipped ahead one slide. Thank you. Now we're okay. Awesome. So what happens when multiple MyPost forms exist? Similar to other advanced care planning documents, when there are multiple MyPost forms, the most recently dated legal document or medical order is recognized. So that's across our advanced care planning document tools. So if a MyPost has been executed after a do not resuscitate order is executed, the MyPost is presumed to reflect the patient's most current wishes. You can take us to the next slide, but maybe we should pause for 1 second and see if that was quite a lot of information, quite a lot of rules. Yes, I'm seeing what is the actual form number. It is 5586. It is the 5836 form. MDHHS, I'll put it in the chat. 5836.
Thank you.
Yeah. Are there any other kind of questions that are coming up just from that first general rule section around the MyPost form?
A lot of information to.
Yeah, a lot of information to take in.
But feel free to unmute yourself and go ahead and ask any questions that you have right now. The question is, does this transfer over from acute care to ambulatory care?
Yeah, that's a great question. So in acute care, the MyPost the answer is yes, because the MyPost travels with the individual patient. And so in an ambulatory care setting, the MyPost is intended to direct care outside of clinical settings. But if we're thinking about specifically within the ambulatory care setting, yes, it does direct care there. In acute care, the MyPost is not binding, but it is instructed that acute care settings should utilize the MyPost as really evidence of the patient's healthcare decisions when evaluating the patients. However, the treatments might differ based on the clinical judgment of the healthcare professional in those settings.
Anyone else?
Yeah.
All right, so completing the MyPost. So I'm going to go through in a couple of slides. I'll go through each section of the MyPost with you, and then we'll look at what the patient and family information sheet looks like. But just kind of for your awareness, before you complete the MyPost, the attending health professional must review the patient and family information sheet with the patient. Again, we'll kind of look at that, and that must be signed and placed in the patient's record. If there is no patient representative, it must be completed. We must recommend that they complete an advance directive because, again, if the patient can't speak for themselves and they don't have any direction on who they would have to make those decisions, we really should encourage them to do so. So after the patient and family information sheet is completed and the patient understands all the things that they've attested to, now you can go ahead and complete the MyPost form, ensuring that all of the signatures are present. So that would be the patient and or patient representative, and then the attending health professional. Verbal or telephone orders are appropriate, but it does need to be signed within 10 calendar days. Next slide, please. So this is
Sorry. There was one question in the chat. I don't know if you wanted to address that now. I can read it if you'd like. How is this supposed to be used in the skilled nursing facility space? Gloria says the communication around this has been confusing over the years.
I'll let you take that, Natalie. And you're on mute, sorry.
Yeah, we've talked about this quite a bit at the advisory committee level and had discussions around MyPost in the skilled nursing facility, and specifically the issue around patients often in the last year of life are moving between many care settings. Skilled nursing facilities, similar to acute care settings, we see that it's used as evidence of a series of conversations around advanced care planning that results in the MyPost, but that treatment decisions in that setting are really up to the provider. We have worked with some of our advisory committee members to think about doing more specific outreach to the skilled nursing facilities around MyPost, just to educate that these documents, once completed, are really considered the result of conversations around advanced care planning and can be very helpful in these situations where someone is in a crisis and their care teams are trying to understand how to honor the patient's wishes. And so we're continuing to try and explore those efforts. I'm wondering if there's maybe if that answered your question, or if there's maybe something more specific, but it is similar to acute care settings in that it's not binding, but is evidence of conversations around advanced care planning and the patient's wishes.
Lori, did that answer your question?
Yeah, so essentially they can't use this as evidence in their site. So if a patient comes over, they have their MyPost, they have their DNR, they are still under the impression that they need to have the documentation re-signed with the guardian or the DPOA within their facility and being witnessed. So that still continues. That hasn't changed.
You cut off at the end there for me.
Just making sure that hasn't changed. That still continues. That they're required to have the DNR and all of that documentation re-signed when they enter their building.
Yeah, the MyPost would need to be reaffirmed at the change of a care setting.
Okay.
Yeah.
Are there any venues that are trying to get that changed? Because a lot of times this is very time consuming for the patient and the family. And then when they switch different levels of care, all of these need to be re-signed. It ends up being a huge barrier. Patients end up being readmitted. I know we've talked about this ad nauseum for a long time. I just haven't seen any movement in trying to consolidate to use this as like one central document to use across all levels of care.
Mhm. Yeah. So the MyPost Advisory Committee that has been meeting over the last year and a half or so, it might even be longer than that, has developed an advisory committee final report that includes recommendations that we presented to the Health IT Commission in August. That is actually one of the recommendations that we included in it. That report is soon to come out. Chris and I were talking just before this meeting that we finally received communications approval to get it public facing and on our website. So there is movement amongst this advisory committee to continue to advocate for legislative changes, because that's what that would require to make that change. Because we hear quite often about, the logistical barriers that are kind of built into the law right now, especially with patients at the end of life, really moving between care settings all the time. And that creates quite a big barrier to keeping these documents up to date.
Thank you.
Okay, so let's review again. So this is the patient and family information sheet. You can see there's a lot of really great detail here. And this is expected to be reviewed and signed by the patient and or patient advocate or their legal representative. And then it should be placed in the patient's medical record for us to review later on. And this should be reviewed by the health professional. Next slide, please. So here is our MyPost order. You can see it's got this big, bright, beautiful pink border, and white cardstock is how it should be presented to the patient. And this is one page, two-sided. And then we're going to go ahead and break down each section so that way you kind of know how to complete this with your patient. And hopefully it'll give you a little bit more detail on how to do that. So you can go one more slide, actually. So this is just the top portion of the patient's patient information. So part one, it's pretty self-explanatory, right? So last name, first name, date of birth, and then the diagnosis supporting the use of the MyPost. Remember, the MyPost is for patients or people with a life-limiting illness. Maybe they have, expected to die within 12 months. So those people, we would want to make sure that we understand exactly what kind of diagnosis would support the use of this MyPost. And then this is a HIPAA permissible document that we can share amongst other care teams if necessary. You can go to the next slide. So this is the medical order section. So there are three sections here, A, B, and C. And we're going to actually break those down just a little bit more. So if you could go to the next slide. So section A is specifically around CPR. So this is when the person has no pulse and is not breathing. So the question is, do they want us to attempt CPR or do they not want us to attempt CPR? If they do want us to attempt CPR, they must choose full treatment in section B, which we'll get to in just a minute. If they do not want to attempt CPR, that means that they want to allow a natural death and no CPR is permitted at that time. Next slide, please. So section B, so this is when the person has a pulse and or is breathing. So there are three different options here. So there's comfort focused treatment, which is the primary goal of maximizing comfort, relieving pain and suffering through the use of medications by any route, positioning, wound care, other measures, such as oxygen, manual suction, airway obstruction, non-invasive respiratory assistance as needed for comfort. Food and water can be provided by mouth as tolerated and may involve transportation to the hospital if comfort needs are not met in their current location. For selective treatment, the primary goal of treating the medical condition while avoiding burdensome measures. So for example, this could be things like IV therapy, cardiac monitoring, non-invasive therapy such as BiPAP or CPAP, and not to use the advanced airway such as intubation. But it may involve treatment and care into the hospital, but preferably avoiding the ICU. And full treatment would mean that we are doing the primary goal of prolonging life by all effective means. So that would include intubation, advanced airway, ACLS protocol, mechanical ventilation, and any other advanced interventions, and including the ICU. Go to the next slide. So again, so if the patient selects attempt CPR, we must choose full treatment in section B. Why do you think that is? Does anybody have any thoughts on this? Why those two go together? I found this to be confusing for some people. That's why I asked. Anybody want to chime in? Otherwise, I'm going to pick on Jessica. Oh, we got a hand up. Carolina?
Hi, Crystal. Well, I could be wrong about this, but my thought is that performing CPR without providing the full treatment is kind of, I don't want to say pointless, but it's really not going to, because you will need all of that supportive, additional, therapy and interventions. You'll have to be intubated to protect the airway, and, potentially be ventilated, and you will need vasopressors and things like that. Most likely so, or maybe other, you may need cardioversion and whatnot.
Absolutely.
Things that come to mind.
Right. You're 1,000% right. I know that in the past when I've done presentations on this, people were often confused why they were forced into kind of making these decisions. But you're right that if this person has no pulse and is not breathing, and we say that we want to attempt CPR, we need to have all the supportive therapies that go along with that. So ACLS protocol included, right? So yes, you're right. Thank you. Next,
Thank you.
And Jessica was happy that you saved her day. All right, so if the patient selects do not attempt CPR and allow a natural death, they can still select any of the treatment options as it be full, selective, or full treatment. This also kind of causes a little bit of confusion to people. But again, remember section A is about CPR and section B is about the medical interventions that lead up to the patient not having a pulse, right? So section B is they do have a pulse. They are, out and about doing their things. Section A takes over when they have lost their pulse and are not breathing. Any questions about this? Okay. Next slide. All right, so section C, this is the additional order section. So this could be about starting, withholding, or stopping a specific treatment, may include dialysis, or really it's kind of person-centered. So anything that really relates to what the patient may have been having troubles with, or things that they know that they no longer want as an intervention. So blood products, feeding tubes, those types of things can be placed there. I would just use caution in making sure that there's no ambiguity in what words you're using. So make sure to have a very clear direction on what that patient or person would want. Next slide, please. So this is sections D through E, and this is just about the attending health professional signature. We're going to actually kind of break that down a little bit more. So you can go to the next slide. So again, this is from the attending health professional. Just as a reminder, this can be an NP, a PA, or a physician. And this is just indicating that they have reviewed the patient's current status, that they agree that this is medically appropriate care to that patient, and that they have received that information sheet that we reviewed earlier. Next slide. So section E relates to the signature of the patient or patient representative. Again, this can be the patient themselves, their legally designated patient advocate, so the durable power of attorney for healthcare, or their court-appointed guardian. I'm sorry. So please make sure that if the patient, especially within the last year of their life, if they don't have a patient advocate assigned already, or durable power of healthcare attorney, it's really, really important that they consider filling out those legal documents to make sure that they actually have the support of that in case something were to happen in the meantime. Maybe they lost capacity, maybe they signed the form, lost capacity, and then there was a change in condition. You really want to make sure that they have that supporting legal document to really make the MyPost form as strong as it can be. Next slide, please. So, so this would be, if you're, maybe it would be you or somebody, an advanced care planning facilitator within your organization, or somebody that's helping the patient fill out the form. This would just be the section where you would put your name and who you are, and that you were the one assisting with preparing that form. Next slide, please. Okay, so to reaffirm or revoke this form, the MyPost can be reaffirmed or revoked at any time. And Natalie's going to review in a little bit some of the requirements around reaffirming. There is only one spot on the form to do that, and the patient can revoke this at any time, in any manner. So whether it be through a new form or a full treatment, or even if they filled out maybe a DNR form. So depending on what's the most current document that they have. Next slide, please. I think this is you, Natalie.
Yeah, so thanks, Crystal. Just to get into a couple of the rules for reaffirming or revoking the MyPost form. The MyPost must be reaffirmed or revoked in the following circumstances. So it expires after 1 year. So 1 year from the date last signed or reaffirmed, it has to be reaffirmed or revoked or completed again. It has to be reaffirmed or revoked 30 days from a change in the attending health professional, the patient's place of care, level of care, or care setting, which we talked a little bit about already, as well as an unexpected change in medical condition. And it just as Crystal was also mentioning, it can be reaffirmed or revoked by the patient or the patient representative in any manner. So if the patient's revocation is not in writing, an individual who witnesses the patient's expressed intent to revoke the MyPost must describe it in writing, the circumstances for the revocation, and that document must be signed by the witness and provided to the attending health professional or the healthcare facility, as well as the patient. Other rules around reaffirming the MyPost. So the MyPost can be reaffirmed. It should include on the form the date of reaffirmation. It must be re-signed by the attending health professional as well as the patient or the patient representative. If there was a change in a completed section, then you must complete the new MyPost form. So the reaffirmation process is for maintaining all the wishes that were already expressed on the original MyPost form. If there are any changes that want to happen, you have to create a new MyPost form. Some rules around revoking the MyPost. In order to revoke the MyPost, the attending health professional or the patient or patient's representative would just simply write revoked over the most recent signatures on the form. The individual revoking the form writes void across both sides of the form. And the patient or patient representative would notify their health professional or the health facility that's responsible for medical treatment of the patient. Awesome, thank you. So in terms of compliance with the MyPost form, EMS is instructed to treat patients according to the orders on the MyPost form unless those services provided are the result of an injury or medical condition unrelated to the diagnosis or medical condition on the MyPost form. So the MyPost form has the section that Crystal was talking about that you need to have a diagnosis supporting the MyPost form. If you remember example Edward, his diagnosis supporting the MyPost form is specifically that congestive heart failure. And so part of our recommendation is for patients that want to have a do not resuscitate order regardless of that diagnosis supporting, they should also consider the out-of-hospital do not resuscitate tool within the advanced care planning process and consider having one of those filled out non-record. The second exception there is really getting at the rules around validity if there are more than one advanced care planning document in place. So the MyPost will be followed unless there's a do not resuscitate with opposite orders that's signed after the date that the MyPost is signed. So in terms of all the advanced care planning documents, if someone has more than one and they're saying different things, the most valid form is the one that was the most recently dated. And then the last bullet there is that it will be followed unless the MyPost is revoked. And just what we were talking about just then, the MyPost can be revoked at any time in any manner according to the legislation. Thank you.
All right. So I did want to point out, because I think, there's a lot of information here. And Natalie had kind of alluded to it a few times that, we've gone to the appropriate groups of people to say, like, there's certain things that need to be in place for the MyPost to be more successful for patients. And again, remember, this is for patients with within the last year of life. So this is likely not for hopefully any one of us on this call. But some of the things that we can do is the family consent law. So in Michigan, we do not have a family consent law. And what that means is we don't have the automatic designation of a patient advocate or a surrogate decision maker by any legal standpoint. So it's really, really important that we ask all the patients or people that we encounter that they fill out a durable power of attorney for healthcare. And what that does is to make sure that we have that legal designation and that supporting document. So whether it's a DNR status or some change in medical condition, we're able to go to that person and they can make medical decisions for that person. So I think that, we're talking about the MyPost today, but I think there's definitely a process and steps. So I would encourage all of you to kind of look at that for yourself. Next slide, please. Okay, so this is a very busy slide, but I think it's really important for, this can be kind of a tool that you can use for yourself. But basically the advanced directive, the durable power of attorney for healthcare, is the legal document. This is for any adult with capacity. They're able to fill this out and designate a patient advocate and or successor advocates that would make their medical decisions for them if they were ever unable to. This particular document does not expire, and copies are acceptable, but it's preferred that you hand those off to your patient advocates and your medical providers. As far as witnessing this, the DPOA does require 2 adults to witness it, and it can't be a family member and it can't be somebody from the medical team that is taking care of that person, or a employee of a health insurance or their presumptive heir. So there are some stipulations around that. There are forms on the that you can print off, whether it be through your own healthcare facility or through the state. There are some documents that you can print out. Now let's talk a little bit about the out-of-hospital DNR. So this is a medical order, and this would pertain to any adult, regardless of health condition. A parent can fill this out on behalf of a minor with an advanced illness. So the person would fill this out for themselves and or their patient representative. And this form can only be signed by a physician, so it cannot be a nurse practitioner or a PA. So we do recognize that that is kind of one of the barriers, is kind of differences in our documents. Again, some of our advocacy work is kind of related to that as well. So on the out-of-hospital DNR order, what's communicated there is specifically do not resuscitate. Again, this has nothing to do with a diagnosis for the adult patient, and it's used as guidance in acute care. So unlike that MyPost form where they can select full treatment or DNR and have different statuses, the out-of-hospital DNR is a do not resuscitate order. It does not expire, and there is no special like form, but there is a specific format that needs to be used. Witnessing requirements, if the patient or patient advocate signs, at least one of whom is not a spouse, we do need to make sure that that it does have the correct signatures on there. As far as the MyPost order, so again, that's kind of the main reason why we're here today. That is a medical order. Again, as a reminder, this is for adults with advanced illness or frailty with 12 months or less life expectancy. So it can be the patient or their patient representative, again, that are filling out the document. And then their physician, NP, or PA can assist with those signatures. Again, this is full treatment, DNR, or and it relates to the comfort, selective, or full. So versus that out of hospital DNR where it's kind of limited on what is allowed, this has kind of more available to it. So this MyPost, it does expire within 12 months. So we need to make sure that it gets reaffirmed by the patient or their designated decision maker. Again, the document does have to have that pink border and it's cardstock, and copies are allowed as well. So there are no witnessing requirements. So that is one of the really great things about the MyPost form as opposed to some of the other documents that we have in Michigan. So there are no requirements for witnessing. Next slide, please.
There's a question. Do you want me to read it? Yeah. When the physician writes revoked over the signature, is the physician required to sign and date after his signature?
No, they're not. They're not. So the way that the revocation works is that they just write revoked over the whole signature line, and once that's on there, it's considered revoked. So there isn't a requirement to have a sign date after that. Also, the MyPost can be revoked by the patient or the patient's representative as well. So they also are not required to sign and date after a signature of revocation.
And Carolina has her hand up.
Yeah, I have a question. Thank you. The previous slide was extremely helpful, but I was wondering, does the advanced directive or durable power of attorney for medical care, does that supersede the MyPost as well as the out of hospital, the middle column? I'm sorry, I don't remember the terminology.
Yeah, I don't know if you could take us back just one slide, Jessica. Yeah, so this question comes up quite a lot. So it falls into the same rule of which is the most recently dated. So if the MyPost is dated after the out-of-hospital DNR and has a different directive of treatment, the MyPost is what is followed. And so, yeah.
But if a person has only the advanced directive, this can suffice as to cover everything else, like in the event of sudden unexpected death, or let's say not necessarily death, but
I think I get what you're kind of asking, Caroline. Are you asking if they have a patient advocate legally designated, are they then able to initiate an out-of-hospital DNR or a MyPost? Is that kind of your question?
I guess not necessarily. So this may sound selfish, and I apologize, but like if I'm thinking of myself not having advanced illness, but I do believe that everyone should have the advanced directive. So if I had something that was legally a legal document, durable power of attorney for my advanced directive, and if I outlined what my preferences are, I don't necessarily need to have the out-of-hospital DNR or MyPost, correct?
Well, you would still want to have those documents in place if that's what you chose. But I think the advanced directive guides that person, whereas the out-of-hospital DNR and the MyPost are the order. So that allows the people like EMS and that to respond to that. Whereas the other one just says what to do.
Okay.
Does that kind of clarify that?
I think so.
I don't know if you had anything else to add, Natalie.
Thank you.
Oh, that was
okay.
Great.
Thank you. All right, next slide. Okay, so again, there's a lot of information, so we're kind of repeating some of this. The advance directive is who the patient wants to designate as their advocate, whether it be family member, non-family member. If they have that documented, again, they can use that person to make sure that those treatment preferences are completed. The advance directive document must be witnessed, and the patient advocate must accept their role as the advocate, and basically understanding all the different nuances that would come with that responsibility. The advance directive oftentimes does have different treatment options available. Again, if it's the advance directive, that is the with a living will, those are just treatment preferences. Those are not medical orders. So the medical orders are the MyPost or the out-of-hospital DNR. So two different things. One is using for guidance for that patient advocate. The MyPost and the DNR are the medical orders for those EMS folks to be able to follow. Next slide, please. So when we're kind of comparing the two, the advance directive is the piece of the puzzle that says who is the person that's going to be able to speak on my behalf. The MyPost is that portable medical order, and it identifies what care to provide if the patient cannot speak for themselves. And the EMS is there to provide that treatment according to their MyPost. Next slide. So the out-of-hospital DNR, again, this is a portable medical order for those that are only wanting do not resuscitate regardless of their life expectancy, regardless of their condition that they have. And it identifies that the patient should not receive CPR should they experience cardiac arrest. This document does require witnessing, so make sure that those are followed. Otherwise, it would just be considered a treatment preference form if it doesn't have the appropriate witnessing. Next slide. So the out-of-hospital DNR versus the MyPost, again, the differences between the two are the out-of-hospital DNR is for any adult wanting a DNR, requires witnessing, and it requires a physician signature. And there is some religious exemptions, which I'm not really going to get into yet, but and then the MyPost is for only adults with advanced illness or frailty, life expectancy of 1 year or less. No witnessing requirements, but it does require a physician, nurse practitioner, or physician assistant signature. And we call that attending health professional. Next slide.
So we like to kind of tail out these trainings by bringing us back to Edward, because I think it kind of already came up in our presentation. If you could take us one slide back, some of the shortcomings around the MyPost form and areas that we've identified that could really improve the efficacy or effectiveness. So it's been a few months after Edward's initial MyPost form has been executed with his attending health professional, which was his nurse practitioner in this case under the MyPost document. And Edward is at home and he experiences shortness of breath and EMS is called. Edward is non-responsive when EMS arrives. They're able to see his MyPost form, the pink bordered cardstock. Generally in EMS protocols, people are instructed to keep it in an easily visible place. So EMS is able to see the MyPost. They see on his MyPost that the diagnosis supporting the MyPost document is the congestive heart failure, but they're unable to determine in the moment in an end of life crisis situation if his non-responsiveness is connected to congestive heart failure. And so they're not able to follow his treatment decisions on the MyPost and transfer Edward to an emergency department where he receives treatment that really was not in line with his wishes. So in practice, what we've realized is that the Michigan MyPost legislation as it reads right now is really not structured to support the realities of end-of-life care. And the MyPost Advisory Committee over the last year and a half has really identified a set of key 8 recommendations to improve the efficacy of the form in the field and has compiled that into a report, prepared it for our Health IT Commission, and is going to be working towards continuing to share those recommendations. And they include things like removing the diagnosis supporting the diagnosis supporting the MyPost from the form. Also, what was kind of mentioned earlier in the conversation, the requirement to reaffirm every time there is a change in treatment setting is onerous on care teams and onerous on different settings. And ultimately, it leads to patients' wishes not being honored. So definitely will share that report with this group so you can take a little bit closer look at the recommendations that we're putting out there. And if you could take us over one more slide. But the advisory committee has been doing more than just the final report with some recommendations. They have helped us to revise and update the MyPost form, that new form that was released in June of 2023. They also created the patient and family information sheet, which is 553. Oh, I'm thinking of the form number because it was asked earlier and it just went from my head. Whatever I said before, it's the one that's 87 at the end. So they've been helping us to create that. The patient and family information sheet, as Crystal was mentioning, really helps patients navigate all those different sections of the MyPost and what they mean. They also helped us to create MDHHS endorsed educational materials for specific user groups. So we have a training slide deck specifically for patients and families. We have a training slide deck specifically for clinical teams. And then we have one additional slide deck created for another stakeholder group. Maybe Crystal, you can help remind me in the chat what the third one is. Oh, what'd you say?
Nursing facilities.
Nursing facilities. So we have a third training there. We also have our frequently asked question document that I put in the chat. So we created a MyPost inbox that has received questions over the last year and a half. We're able to respond to individuals through that inbox, but also keep a frequently asked questions document running for other individuals that might be running into those same questions around the MyPost. So that's a really excellent resource for some of these more thorny questions that you guys were asking today. We also were able to work with translation services to make sure the MyPost is available in Spanish and Arabic. And this group has really also supported a number of educational opportunities across the state around MyPost over the last year and a half. And we're continuing to do outreach to different groups that touch clinical teams that support patients that might be interested in completing advanced care planning documents. So we've been up to quite a lot, and this is one of our educational outreach activities. I think we have exactly 2 minutes for questions, although it was great to see some of them coming through during the presentation. There's our contact. I will drop the MDHHS MyPost inbox in the chat. If there's additional questions, we can take them there. Or if anyone has questions now, please feel free to unmute. And
thank you so much, Crystal and Natalie. We will be happy to share your contact information as well, since there is only just a couple of minutes left and folks may have questions that take a little longer than that. Feel free to continue typing questions in the chat, but I'm going to go ahead and just share out what I know some folks are waiting for so that they can move on if they need to. But as a reminder, all of our work groups are virtual. We have our last one for 2024 coming up December 12th, and that will be a rural health work group presented by Tony Moriarty Smith from McLaren, Northern Michigan. And then we do have our 2025 work groups on our website now. Rachel will be dropping in the chat the link for the survey that you all need to fill out if you would like to get the P4P credit for your attendance today. And then I'm just going to go back and display this again for anybody that didn't catch it, because that's really all I had.